I think this is a something that I'd like to probably do on a recurring basis, especially when we have like an influx of new people. But I think this is really valuable, and I try to clear up some of the maybe misconceptions, or maybe sometimes a lot of things we do, we don't realize why. So I hope this attempts, or does, clear this up a little bit. Okay. So I want to start with a case. And sometimes this is better suited for like actual rooms with whiteboards. But so I have a 39-week infant of a diabetic mother who is GBS positive, who did not receive penicillin prior to delivery. CBC was done appropriately at 8 hours, and is as follows: white cell count of 19, hemoglobin of 26, hematocrit of 74, platelet count of 200, 71 neutrophils, 10 lymphocytes, 5 monocytes, 1 eosinophil, and 2 bands. Can anyone point out what the problem is? Maybe you can do it through the chat. If anyone wants to.
Mom is GBS positive.
That's one thing, but there's something in the CBC that
White
is
count high.
no. I mean, it's maybe high for an adult, but we see the white cell count of 19,000 frequently. Yes, the hematocrit is high. The hematocrit is high. It's 74. Okay. So what is polycythemia? The definition of polycythemia is generally a venous hematocrit above 65, or a hemoglobin above 22. It means that there's an abnormally large number of circulating erythrocytes in the bloodstream. The incidence in healthy newborns is between 0.4 and 5%. Risk factors include being post-term, being small for gestational age, being an infant of a diabetic mother, twin transfusion, the donor of the twin transfusion, chromosomal abnormalities, placental insufficiency, maternal thyrotoxicosis as a result of Graves' disease, which we see sometimes. What happens is there's an increased viscosity or thickness of the blood. So instead of blood flowing, as you know, think of water versus a milkshake. Okay, the milkshake clearly flows a lot less well than does water. So that results in decreased microcirculatory flow through like the capillaries at the distal ends of the bloodstream. Most babies, as you guys have probably seen or noticed, remain asymptomatic, but they can become lethargic, hypoglycemic. They could have jaundice. They could have feeding difficulties. At worst, they could have apnea, cyanosis, respiratory distress, or even seizures. So why do we ask for a venous sample every time we have a high hematocrit like that? Well, capillary samples have approximately 82% correlation with venous samples and 77% with arterial samples. The capillary site has a higher hemoglobin concentration and higher hematocrit value due to sludging of the RBCs in the lower flow distal capillaries, and then transudation of plasma out of those capillaries. So the hemoglobin and hematocrit could be 5 to 15% higher in a capillary sample. What do? Well, if a baby's symptomatic, you hydrate. Well, first you can draw blood. Like one way to improve the situation is to do serial venous blood draws. But if they have to go to the NICU, we can hydrate them with IV fluids and then repeat the H&H in 12 hours. Other things that are important to monitor, as I outlined in the symptoms, monitoring blood sugars, jaundice level, and the clinical status of the infant more closely. And at worst, these babies might need exchange transfusions. Rarely do we have to do that. So basically what this is taking baby's blood out and replacing it with colloid or non-colloid fluids, like saline or even albumin. Okay. So any questions about polycythemia? I do see the chat, so you guys can type it in. Okay, well, so I want to move on to what are the normal values in a neonate? Well, there actually aren't any normal values because usually we're drawing blood on a neonate because we think that something's wrong or the baby is sick, right? So we can't necessarily call the values we see based on that normal, right? So a group out in Utah in 2015 tried to address this issue, and they drew blood in 350,000 individual, 100,000 individual babies, but 350,000 individual actual values in Utah and Idaho. They of course excluded babies who needed blood transfusions. So again, we could only call things normal if we get them from normal people, right? So we don't really have normal babies who volunteer themselves to draw, provide blood samples for us, right? So what is traditionally called in the normal range is excluding the lower 2.5% and the upper 2.5%. So the way they alleviated this issue is they narrowed their quote unquote normals a little bit. So in a reference value, in a reference interval, they included the values between the 5th and the 95th percent. So they excluded 10% of the upper and lower ends to account for the fact that we don't really have normal values in neonates. Everybody, is that clear? Did I explain that in a clear way?
Yes.
Okay. So hopefully this chart isn't too blurry, but these are the reference values that they found. And I drew red arrows where at the 36-week mark, because that's generally where we see kids. And, you know, down in the nursery, you might see a 35-weeker here and there, but this is where we generally see our kids. And as you can see, the upper and lower levels of the hemoglobin for a 36-weeker are about 13.5 or so on the lower limit, and then about 21.5 or so at the upper limit. There's a question, do we have higher hematocrits if we do delayed cord clamping? That has been, that is one of the, not controversies, but one of the sticking points about delayed cord clamping. And anecdotally, I don't think I have seen increased polycythemia because of delayed cord clamping. Somebody needs to do, there might be a study out there, but somebody needs to do a study about that. And the other thing is increased jaundice. I don't feel like we've seen increased jaundice either. I think it's about the same as before we started doing delayed cord clamping, but theoretically that is what the thought was. So here are the upper and lower hematocrit values, about 40 and about 65-ish or so. And that makes sense, right? Okay, and this should be included in your handout. Okay. So what do the other indices mean? We see all these values on the CDC, but we don't always use them, right? So most of these values are more important for when you are trying to diagnose things like hereditary spherocytosis or elliptocytosis or folate deficiency or iron deficiency anemia. We don't necessarily use these values on a day-to-day basis. So the MCV is the mean corpuscular volume. It's the average size of the circulating erythrocytes. Keeping in mind, neonatal erythrocytes are larger than adults, so they will have higher MCVs. MCH is the mean corpuscular hemoglobin, the average amount of hemoglobin in circulating erythrocytes. MCHC is the mean corpuscular hemoglobin concentration. RBCs are, of course, the number of circulating erythrocytes. And what sometimes hematologists do if there's something abnormal is look at the peripheral blood smear and look at the shape of the actual the blood cells. Sometimes you might see things like schistocytes or elliptocytes or spherocytes in a normal neonate sometimes. But generally, we won't be, the hematologists are the ones who are using these most of the times, or if we see something concerning, then we will refer to hematology. Okay. So here's another case scenario. 39-week infant of a diabetic mother, GBS positive, again, not treated prior to delivery. CBC at 8 hours is as follows. The white cell count is 26,000, hemoglobin of 19, hematocrit of 54, platelet count of 200,000, 60 neutrophils, 10 lymphocytes, 5 monocytes, 1 eosinophil, and 10 bands. What's the potential issue here?
Bands.
The bands are high. Now, are they high enough to a actual significant level that is evidence-based? And how do I figure that out? What can I do? What calculation can I do here? Yep, you compare with the segmented neutrophils. Now, it's not just comparing them, it's actually more than that, and I'll get into that. So, white blood cells, neutrophils, and bands. So, what are white blood cells? They're split up into two types. There's granulocytes and agranulocytes. Agranulocytes being like lymphocytes and such. Neutrophils are granulocytes. They're phagocytic cells that are the first types to migrate to infection sites. But they don't come out of the bone marrow as neutrophils already. They go through a stage of development. They start out as myeloblasts, then become promyelocytes, then become myelocytes, then become metamyelocytes, then become bands, which are immature neutrophils, and then they finally mature into mature neutrophils. Immature neutrophils are, of course, they're released with more demand, such as an infection or other reasons as well, cancer, malignancies, etc., maybe drugs as well. So you guys have probably seen these things on CBCs, on the differentials, and wondered what they are. Well, they're immature neutrophils. They're in the stage prior to bands. Why do we ask about bands? So neutrophilia, which is increased neutrophils, can be due to inflammation, malignancies, drugs, or even steroids. Neutropenia, lower white blood cells, or lower neutrophils, I should say, can result from pregnancy-induced hypertension, birth asphyxia, IUGR, even Rh hemolytic disease. And this neutropenia, rather than neutrophilia, is more predictive of an infection than neutrophilia, okay? So the calculation that you do is you do the immature to total neutrophil ratio. And 0.3 or 30% is suspicious for infection. So you add up all those immature neutrophils, the bands plus the myeloblasts plus the promyelocyte plus the myelocytes plus the metamyelocyte, and you divide that by the total number of neutrophils. So it's not just the segmented mature neutrophils, but it's all of them, including the bands, the myoblasts, blah blah blah. Okay. So what is that in this case? So it's 10 divided by 70. So that's not quite 30% or even 20%, right? So yes, it is concerning and something that will trend in this case, but even though it's 10 bands, even though it's double digits, that doesn't necessarily it's not necessarily indicative of a suspicion for infection. Does that make sense? Okay. So now here's a interesting tidbit. So one study in 1979, and actually two studies, 1979 and 1994. These two authors analyzed 30,000 CBCs in the first 72 hours of a neonate's life. And they found that peak neutrophil values generally occur 6 to 8 hours after delivery for infants greater than 28 weeks. During the first 18 hours after delivery, neonates of mothers who had labored had significantly higher neutrophil counts. And so stress, like the stress from delivery, can cause neutrophil counts to be a little bit higher. Females, interestingly, had higher neutrophil counts than males. Okay, so that is another supporting fact of why we do CBCs at 6 to 8 hours. So here's another chart, just really showing, again, that peak absolute neutrophil count, meaning all of the neutrophils it peaks at about 6 to 8 hours or so, as indicated by the red arrows. Okay. So I borrowed a few slides from my other PowerPoints, and just to, again, support some of the information, like support why we do certain things. So the CBC with manual differential. So again, neutropenia may be significant, but it is also found in healthy growing VLBW neonates. In general, in the nursery, we won't encounter that, but for you, us NICU folks, we'll see it more often. So the I to T ratio can be elevated in actually almost half of uninfected neonates. Other conditions can alter neutrophil counts, such as maternal hypertension, fever, neonatal asphyxia, oxytocin, a stressful labor, meconium aspiration syndrome, pneumothoraces, and even prolonged crying. So single CBCs, one CBC has a good negative predictive value if it is normal. So that's kind of why we stop when we see just a normal CBC. What this negative predictive value means is that you can count on the CBC as a good rule out test. Okay. If you have a normal CBC, 99% of the time you will not have an infection. Okay. So this doesn't count the other way. So this doesn't mean, so if you had a good positive predictive value, if I had a 99% positive predictive value with a test, that means if I do the test, I can be 99% sure that this person has this disease. But in a negative predictive value, you use it to rule out the condition. Does that make sense? So that's why we do serial CBCs to establish a trend. Okay. This is a wordy slide. Any questions about the previous slide? Any questions about the negative predictive value? I think that's something important to really get. Okay. So how good is a CBC actually? In 2003, one study that looked at 20,500 deliveries found 1,665 asymptomatic infants at risk for infection, and they were evaluated. They did a CBC and a blood culture within 4 hours of life. Only 17 of these babies actually developed early onset sepsis, 1%, all within 48 hours. So that's where the 48 hours of observation kind of comes in, okay? The white blood cell count was abnormal in 7 out of the 17 infants, and in 447 of the normal other 1,600 infants who didn't have sepsis, okay? None of the 1,665 actually had a positive blood culture. They were, clinically diagnosed with sepsis, okay? So the sensitivity and specificity of abnormal white cells in predicting which at-risk newborns would actually develop sepsis is 41 and 73%. Not that great, right? So you can't rely on just one CBC to diagnose, okay? Does that make sense? So, basically what I'm trying to say is a white blood cell count can be abnormal in a septic baby and a normal baby. Can't rely on it completely, okay? So how good is a CBC? So there is a statistical test you can do called the area under the receiving operator curve, okay? And it basically tells you whether your test is good. So it's kind of like just the normal grading system. 90% to 100% is excellent, 80 to 90 is good, 70 to 80 is fair, 60 to 70 is poor, below 60 is really bad. So the accuracy of the test in terms of the white blood cell counts, it scored 0.52 in less than an hour. So terrible test, fail test in less than 1 hour. But a great test, or a good test anyway, a B, 87% at greater than or equal to 4 hours. So again, supporting information of why we do our CBCs at 6 to 8 hours, okay? Fevers. Now we deal with fevers a lot. We get calls about moms who have gotten fevers before or after the fact a lot. How good is a fever? Like, what does that tell you? So it looked at, there was one study in 1997 that looked at 1,650 women who had intrapartum fever greater than 100.4. Oh, wait, so here, sorry. Intrapartum fever greater than 100.4 occurred in 14.5% of women receiving epidural, but only in 1% of moms not receiving an epidural. Does that make sense? So fevers occurred in women who had epidurals more often than they occurred in women who did not have an epidural. Okay. Neonates whose mothers received epidurals were more often evaluated for sepsis. And of course, that does happen, right? With us, we get CBCs when we're alerted that a mom has had a fever. They were evaluated more, 34% compared to 9.8%, and treated with antibiotics more, 15% versus 3.8%. 96.2% of intrapartum fevers, 85.6% of neonatal sepsis evaluations, and 87.5% of neonatal antibiotic treatment occurred in the group of infants who were born to moms who had epidurals. So way more often, right? Of the total 416 infants evaluated for sepsis, only 4 infants had documented sepsis. 1 infant whose mother did not receive an epidural, and 3 mothers who did receive an epidural. So I'm not advocating for any practice change or anything like that. I'm just, this is just food for thought. This is just something to think about when when we have our moms with fevers. Okay. Any questions about the previous slides? Okay. Another case, 39-week infant, IUGR infant, born to a mother with preeclampsia that is 2,100 grams. The CBC at 8 hours is as follows. White blood cell count of 12,000, hemoglobin 19, hematocrit 54, platelet count of 99,000, 70 neutrophils, 10 lymphocytes, 5 monocytes, 1 eosinophil, 1 band. Can anyone point out the issue here? In the chat is fine. That's right, platelet counts. So hold on 1 second. Okay, so okay, so what do we need to make sure of? We have a kid with thrombocytopenia. What do we need to make sure of? Anyone? Yes. That's one of it. So what I'm searching for is related to whether or not to do a circumcision. What are they at risk for? And not just from a circumcision either. Bleeding, yes.
Bleeding.
The most
Vitamin K administration.
yeah, we need to make sure that we give it. Yeah, for sure. And we need to be. We should be giving it to everybody. But yes, bleeding anywhere, not just the brain. I mean, brain, yes, brain, absolutely. But that'd be the worst case scenario. So yes, bleeding. And that's not the only symptom. They could have bruising, easy bruising. They could have petechiae, purpura, mucous membrane bleeding, those types of, or maybe not their bleeding doesn't stop after a heel stick or something like that. Okay, so thrombocytopenia is typically defined as a platelet count less than 150,000. It occurs in fewer than 1% of all newborns, with the highest prevalence being in those of low birth weight, preterm infants, and sick infants in the NICU. It's frequently due to maternal pregnancy-induced hypertension, IUGR, and/or placental insufficiency. However, in those cases, the platelets typically recover in 2 weeks. Okay. So why should we worry? So yes, it can manifest as bruising, petechiae, or worst case scenario, bleeding. Severe neonatal thrombocytopenia is typically defined as a platelet count less than 50,000. that can result in intracranial hemorrhage, pulmonary bleeding, or GI bleeding. Although we don't often see that, it's a risk. Okay, can be due to, so this thrombocytopenia can be due to severe perinatal asphyxia. It could be due to perinatally acquired infections in the case of like bacteremia or sepsis with GBS E. coli, among others. Of course, we can treat those things. CMV can cause thrombocytopenia as well. It can be caused to autoimmune or alloimmune thrombocytopenia, which is related to why we ask for a platelet count if mom had thrombocytopenia, because we need to make sure it's not autoimmune. It could also be due to various other infections, as well as genetic disorders, inherited platelet disorders, which are really rare, and platelet-consuming tumors as well. Okay. And here is the reference chart of platelets for all infants. And the red line is where 36 weekers are. Generally, that the lower limit is 115 or so, with the higher limit, thrombocytosis, being like above 350,000. So what does thrombocytosis mean? So platelets can be a acute phase reactant, so they can increase in amount when somebody has an infection. So like above 300, like if you see a platelet count above 350, 400 or so, and that's something to watch out for as well. Anemia, I'm not really going to talk about anemia much because we kind of, I mean, it's kind of clear why we would worry about that. And generally for our case, usually the anemia would be due to acute blood loss, like in the case of a placental abruption or a maternal fetal hemorrhage, or in hemolytic disease such as ABO mismatch, RH incompatibility, or even the minor blood groups as well. The most important thing for you to recognize is symptomatology, and that would be lethargy, paleness, hypotension, poor capillary refill. I do remember a case we had a while ago where the baby was born completely pale, terribly pale, and the hematocrit was like 20 or something, 19 or 20. And so that baby had to come up for blood transfusions. And that baby was symptomatic. That baby was lethargic, tachycardic, hypotensive. So I think that's an easy thing to recognize for you guys. And okay. All right. So any questions about anemia? Okay. So moving on to hyperbiliary. So I just kind of wanted to give you guys kind of an idea of what we see as the physicians and neonatologists in terms of people with or babies with hyperbiliary, and what kind of amount it could be, or how many times we have to see these numbers. Okay, so let's take a look at an example of a NICU census. 3001, 36 weeker, Coombs positive, TCB 7.9 at 24 hours. 3003, 39 weeker, Coombs negative, TCB 7.8 at 24 hours. 3004, 35 weeker, Coombs positive, previous sibling with phototherapy, TCB is 9 at 48 hours. It goes on and on and on. 2006, 2007, 4 kids on phototherapy on this slide. We're not done, right? So I didn't even use all the rooms. So with all these kids with similar sounding bilirubin levels. 3023, a 39 weeker, Coombs negative, serum bili 9.9. 3025, 39 weeker, Coombs positive, on phototherapy, serum bili 15 at 48 hours. It's a lot, right? I know it's a lot for you guys, but it's a lot for us as well. Not done. We have babies in the NICU on phototherapy too. NICU bed 1, 28 weeker, Coombs negative, on phototherapy, serum bili 9.1 at 96 hours. NICU bed 2, 29 weeker, Coombs negative, on phototherapy, serum bili 10.1 at 72 hours. NICU bed 3, 34 weeker, Coombs negative, serum bili 5 at 72 hours. NICU bed 4, 36 weeker, Coombs negative, serum bili 5.1 at 72 hours. Okay, it's a lot of numbers, right? And it's not easy to judge these numbers in isolation, right? So case scenario, the baby in room 3023 on the previous slide has a TCB of 10.2 at 24 hours of life. the serum level is drawn and the serum billy is 9.9. What other pieces of information should you know? So gestational age, Coombs status, the previous bilirubin level. What's the light level? Is the baby on phototherapy? Sometimes, often, I'll get pieces of this. Get the gestational age, Coombs status, but sometimes I won't. Sometimes I won't even get like what the previous level is. Well, in this case, it's the first test, right? What is the light level? In general, like for a full termer, we'll probably have a lot of these memorized at 24 hours, but it changes as we'll see in the charts later. It changes as the hours of life change, right? And oftentimes we get these numbers, sometimes when we're intubating or sometimes when we're with a patient. So, we're not able to just stop and plug it into BillyTool and necessarily know exactly where the baby falls. Is it high risk, high intermediate risk? Is it above the light level, below the light level? Okay, in this case, it's a term baby, Coombs negative. And where does he fall? He's high risk. Oh, wait, no, sorry. He's high risk. So he's a lower risk category because he's full term, but he's still in the high risk zone. Okay. The light level in this case is 11.7. 11.7. Okay. So what if we had the same jaundice level, but if but the baby was 36 weeks? That changes things a lot, right? And the baby is Coombs positive. So then this baby is in the high risk, but above the light level. So in the first case, in the term baby, we'd watch, right, and redraw. But in this case, we'd have to treat this baby, right? So these numbers need to be in a certain they need to include context, and a lot of you are really good at including that context. But in isolation, just the number by itself is not enough information. Okay. So third case, the baby in room 3023 has a TCB of 13.5 at 65 hours of life. The serum level is drawn. Serum billy is 15. What other pieces of information? Yes, gestational age, Coombs status, previous bilirubin level. What is the light level? Is the baby on phototherapy? Okay. So what is anybody's guess? What if this was a term baby? Are you guys plugging it into BillyTool? It is higher intermediate. It is higher intermediate. But this baby's not 39 weeks. The baby's actually 37 weeks. Coombs negative. Okay, so it is higher intermediate. But if this baby was 37 weeks, which is what we've traditionally called full term, right? The baby's still medium risk and still needs to be treated at 15. Okay, because this baby falls in the medium risk category. All right, so they're just subtle, little differences in the numbers that can happen just based on gestational age. It is, in the end, it is the neonatologist's job to interpret the numbers, but we need context. And as advocates for your patients, it might be a good exercise to plot the numbers. The last thing we want is to send a baby home or discharge a baby and they're in the high risk zone or higher intermediate risk, and all of a sudden they develop kernicterus at home or something like that. So yes, again, it is our job as neonatologists, the physicians, to, in the end, make the final decision. But again, like I said, we can be receiving 2 or 3 of these numbers on a phone call while we're bagging a baby or intubating a baby or doing whatever lines. So yeah, just as advocates for your patients, maybe this is a good exercise to do. Okay. So everybody knows this chart. The risk zones. Basically, the risk basically means what are the chances of this baby eventually needing some kind of treatment. Okay. But another chart that's important is the phototherapy, the AAP phototherapy guidelines. This tells you if you should treat at that moment or not. With the bottom line being the higher risk, the preemies, or the terms with risk factors, medium risk being the middle dashed line, and the term infants greater than 38 weeks without any risk factors being the upper dotted line. Okay. I'm sure you guys have this chart on you. So what do we tell parents about jaundice? It's very common. 60% of term and 80% of preterm infants develop jaundice. It's a normal physiologic process. Bilirubin is a product of recycling of the red blood cells. In utero, it's the maternal liver that's taking care of the fetus's bilirubin. And newborns normally develop jaundice because they recycle their red blood cells 2 to 3 times faster than we do. And the chemical processing of the bilirubin by the infant's liver is not yet mature. There are other reasons as well, such as increased enterohepatic circulation, decreased intestinal flora, what we'd call breastfeeding versus breast milk jaundice, etc. But I think this is enough information for parents to know. This is just a diagram about how Rh disease works. So you have an Rh negative mother who is naive to the Rh antigen, which dad has. They have a baby who is Rh positive like dad. Mom is naive to that antigen. The baby's blood at some point, whether it be around delivery or beforehand, enters mom's bloodstream, and she develops antibodies against it. So the subsequent pregnancy, she has those antibodies and they attack the fetus's red blood cells. Okay. Any questions about that at all? Pretty clear, right? This is just a diagram showing you that Rh is not the only antigen on the surface of the red blood cell. Actually, there are dozens, maybe hundreds of them. Okay. What we're most familiar with is, of course, the ABO, A or B antigens on the surface, the Rh, okay, but there are many different others. Kel antigen, Duffy antigen. You may have seen in some mother's charts where it says that she's anti-E positive or something. That's what that means. It means they're sensitized to one of these other minor blood groups. These are all blood groups. ABO isn't the only blood group. Rh isn't the only blood group. There are a bunch of others as well. Okay. And traditionally, they don't cause hemolytic disease as badly as ABO or Rh, but they can cause hemolytic disease. Bilirubin neurotoxicity. So this is why we are so aggressive to treat jaundice. You've all heard the term kernicterus, also known as acute bilirubin encephalopathy. It happens a lot in third world countries, but doesn't happen nearly as much here. It occurs in 0.5 to 1.3 per 100,000 births. Should be considered if the total serum bilirubin level, that's what TSB is greater than 25, or if the baby is symptomatic, because you can have kernicterus at lower levels. And you should consider a lower level if it's preterm. We'll explain the cause of Coombs positive. So Coombs, the direct antiglobulin test, is basically testing whether or not mom has been sensitized to a different blood group. That's what Coombs. That's I think Coombs is the name of the person who created the test. But it's essentially testing whether or not the mom's been sensitized to one of these blood groups in this picture right here, ABO. Like if she's an O and she's been exposed to A or B from the previous baby or the current fetus, to test whether or not she's created antibodies against them. I forget how like there's direct and indirect antiglobulin tests. I can't remember how. I mean, that's a lab question. I don't remember exactly how that works. But oh, Anais, Billy tool lets you calculate starting. Well, Billy tool lets you calculate starting at 12 hours of life. I know if we have a Coombs positive baby and TCB is 2 or more at 2 hours of life, we draw serum. How do we know what value to call? Notified provider if the infant is less than 12 hours. I usually say if the hours of life are close to the actual bilirubin level, like if it's 4 at 4 hours, you know, 6 at 6 hours, or even 6 at 8 hours, something like that. I'd be worried about that. I mean, if it's only 2 hours, if the baby's only 2 hours of age, I may just still ask for transcutaneous levels every 2 to 4 hours or so, and not necessarily get a serum right away. But if I have a couple, like, you know, if the baby is 2 at 2 hours and then suddenly like 6 at 5 hours, it still remains like 6 at 6 hours or something like that, I'd be worried. I'd probably start that baby on phototherapy. But I usually, you know, rule of thumb, if the jaundice level is close to the hours of life, that's my personal rule of thumb. Okay. Did I explain the Coombs positive thing enough? Okay. So again, acute bilirubin encephalopathy, 25 symptomatic, maybe a lower level of preterm, like a baby who's preterm and the jaundice level is 18 could have kernicterus. So phase 1 of acute bilirubin encephalopathy, poor suck, hypotonia, lethargy, jitteriness. Phase 2, retrocolitis, hypertonia, opisthotonos, basically really severe arching. Phase 3, seizures, apnea, possibly death. Okay, they're all reversible. Phase 1 is most reversible. 2 and 3 could be reversible depending on how aggressive you are, how quickly you are to treat. And one of the big reasons, again, we're aggressive to treat this is long-term effects. Chorioathetoid cerebral palsy, sensorineural hearing loss. There could be possibly subtle changes in a person as they grow older. They could have auditory, not necessarily just deafness, but you know, they could have hearing problems, learning disorders. It's been found that people could have behavioral, even psychiatric disorders in the future, as well as finding gross motor incoordination as a result of bilirubin neurotoxicity. Any questions at all? So I figured I'd throw something a little bit in here about the treatment and how it works regarding phototherapy. So if you guys remember from chemistry or physics, where certain atoms, like atoms have a distinct, the electrons in atoms have a distinct energy level, and only a certain energy level can kind of knock that electron from energy level to energy level, right? It's kind of the same principle with the bilirubin molecule. There's a specific wavelength of light, specifically in the visible spectrum and specifically in blue wave light, that is enough energy to change the chemical configuration of bilirubin into a level, into a isomer that is water soluble and thus can be urinated out and not just stooled out. That's the, like I've heard some people have, not lately, but some people have said, oh, it's UV light or it's infrared light. No, it's just blue light. It's literally blue visible spectrum light. And the wavelength that is most effective is between 460 and 490 nanometers. Okay, and it changes the chemical configuration into an isomer, type of isomer that is water soluble, so that baby can pee out. Any questions? All right, that's basically all I have. And these are my references, and I encourage you guys to go through some of these references. They're really these were some nice articles that I found about reference ranges of the CBC and hyperbilly too.
Dr. Lee, thank you so much for providing your time and expertise. This was a fabulous overview of our neonatal labs. Does anybody have any questions for Dr. Lee before we end?
No, thank you, Dr. Lee.
No, thank you so much, Dr. Lee.
You're welcome.
Thank you, Dr. Ling.
No problem. So just a technical question. I had my chat open on the right and all the cameras open on the, not all of them, but did anybody see that? Like, do you just see my slides?
We just saw your slides, yes.
Oh, excellent. Cool. All right. Zoom.